Good morning, everybody, and welcome to the November 2025 Hospital Stakeholder Engagement Meeting hosted by the Colorado Department of Healthcare Policy and Financing. We are now at about 5 after the hour, so we'll go ahead and get started. Next slide, please. All right. So once again, welcome. To introduce myself, my name is Andrew Abalos. I am the Facility Rate Section Manager here at the department, and I will be hosting or doing a lot of presenting during today's meeting. So thank you for your participation today and joining. We really do count on your participation to help make these meetings successful. We think of these as an important way to continue the dialogue with hospitals on anything related to operational concerns or rate reform or anything like that. So your engagement is very important. Next slide, please. So a few things about this meeting. We do record those meetings, as you were probably alerted about just a couple of minutes ago. We post these recordings online to our hospital engagement meeting website for later viewing. We try and get those posted generally early on in the week following the meetings. So because we're also recording these meetings, if you speak, please announce your name and the hospital that you represent when you're speaking, just so that way we can track back and make sure that if we need to do any follow-up after the meeting, we know who to reach out to. And if you do speak, make sure that you are in a relatively quiet area, just so that way there's not a whole lot of background noise. That way we can help preserve the integrity of those recordings. And then we do think of these meetings as somewhat collaborative in how with the topics that we want to present. So if there are any topics that you would like to see discussed within these meetings, please let us know. You can email Della Fawn. Her email is on this slide here. And we request that you give us about 2 weeks or so, probably longer, before you make these types of requests. This is largely to allow us to do any kind of preparation or research, or even just get the meeting on the calendar of the SME who would be discussing that topic. So appreciate your cooperation there. Next slide, please. Okay, so this is the final of our scheduled meetings for 2025. So we could go ahead and move on to the next slide for the 2026 meetings. All right, so we are continuing the cadence of bi-monthly meetings. We'll be starting back up in January of 2026, and we are maintaining the same philosophy of the first Friday of every odd month, except for those Fridays that would land on holiday weekends, in which case we push it to the following Friday, and we push it to the afternoon as well, just to make sure our meetings aren't interfering with the Medical Services Board's meetings. Oftentimes we know several people that attend these meetings want to attend those as well. And in the case, some of us at the department have to present at the Medical Services Board meetings as well. So we don't want to create any conflicts there. Okay, and next slide, please. Okay, so here is our agenda for this meeting. Go ahead and stay on here for just a moment. All right, and we could go ahead and move on to the next slide, where I believe Corey is present to speak to this one. So Corey, I'll pass it off to you.
Good morning, everybody. I am Corey Conolog, and I am the Pharmacy Policy Specialist with the department. And I just wanted to communicate a little bit of billing guidance about a new program that HRSA is rolling out. So in January, the Department of Health Resources and Services Administration, HRSA, is implementing a new 340B rebate model pilot program. So under this program, instead of receiving an upfront discount on 340B acquired drugs, manufacturers are going to be issuing rebates after about 10 days after the claims are invoiced. So instead of billing the department for the pre-rebate price, our billing instructions is to bill the department for the submitted ingredient cost after the rebate, which is equal to the 340B ceiling price. And covered entities should have access to those ceiling prices through the Office of Pharmacy Affairs information system. And if there are any more questions, please reach out to me, and my email address is on the slide.
Great. Thank you, Corey. Okay, not seeing any questions yet. I think we could go ahead and move on to the next slide. Corey, if you want to stick around just in case people have questions, that'd be great.
Sure.
All right, and so we're passing this back to me. This was actually a continued topic that was brought up during our September engagement meeting. We did have a provider who reached out wanting to know more, particularly who to contact for instances where there's mismatching information on Medicaid members between the Medicaid provider portal and the CBMS. We're still working to make sure that we're understanding what the scope of the issue might be. And really what we're hoping to get is more instances where this is the case. So this is sort of a passive call to action here. If there are instances that you have identified where this mismatching information is observed, particularly as it might impact the claims adjudication process, please send any instances of those mismatches to the email address that's listed on this slide. And if you can, please include the ICN number of any claims that were impacted by these mismatches. And that can help us better understand the issue and really drill down to who exactly needs to, who can be the point of contact for handling these problems. Okay, and next slide, please. All right, so just wanted to go over a few of the EAPG rate changes effective July 1. This is largely similar to what we discussed back in September with only a few small updates. So as mentioned back in September, we are still working on the system change request with our fiscal agent for the implementation of EAPG version 3.18. That is to be effective July 1, 2025. Alongside that version change transition, there are a few other changes that will be implemented at the same time. One of which is the 1.6 EAPG base rate increase that was part of the long bill effective July 125, and the 340B rate reduction that we also introduced at the same time. So alongside that, we have, since our last meeting, the executive order was signed, which would roll back that 1.6% rate increase on October 1, 2025. So now that we've moved past that date, we are planning to introduce that at the same time. In our most recent conversations with our fiscal agent, Gainwell, they were targeting the project completion for within the fourth quarter of this calendar year and have since provided a more solidified date that they are targeting December 17th. So what we're anticipating is that around that time, we should have the system fully updated to pay using version 3.18, and no action should be required on the provider's part because we will be reprocessing any of those impacted claims to pay at their correct rate, version, and weight. So once we do get more information around when that SCR will be completed and the reprocessing will happen, we will be sending out an email to our usual email list that we use, where we typically announce rate updates and postings and anything else pertinent that don't fit within the cadence of our provider bulletins or these meetings. So we do have a link to more information on our outpatient hospital payment site for EAPGs and the related rate change. If you do have any questions, definitely check out that site. But otherwise, we can always answer questions via email as well. So at the end of this presentation, we have our email addresses. We're happy to discuss more about how this will all work then. And next slide, please. All right, great. So the EAPG module updates. So Solventum actually released a service pack update that we needed to install within our system, our MMIS, just to make sure that EAPG claims were processing correctly. This was released on October 23rd, and it was installed into the interchange system on October 27th. This was partially a follow-up to applying the quarterly CPT HCPCS updates. I also believe that the ICD-10 annual updates were included in this as well. But those went through initially as part of our general availability install. We had actually identified a separate issue where there was some claims that had the interface had broken in certain instances for EAPG claims, but those issues have been resolved. There should have been no reprocessing required from any of that, but this was just part of a non-standard release schedule that we needed to adhere to in order to make sure that both the quarterly coding updates were accommodated and that our system still worked to price EAPG claims. So no concerns there. But otherwise, we do have an upcoming general availability release for EAPGs coming out in early or late 2025 to impact the 2026 code set updates. We anticipate that we can get this installed within our interchange system within that same week. Usually they happen on the Wednesday after the release of the module. And again, this will apply the CPT HCPCS updates around that time. Okay. And next slide, please. All right, so I think for the next handful of slides, I'm passing it off to Diana.
Thanks, Andrew. Hi, everybody. I'm Diana Lamb. I'm the inpatient hospital rates analyst. And I just wanted to give you a couple updates. The inpatient base rates effective 7/1/2025 and 10/1/2025 were implemented into the claim system, and all claims with ending service dates of July 1, 2025 and later were reprocessed during the October 3, 2025 financial cycle. We did send an email to everybody on the hospital engagement meeting newsletter list on October 17th. Here's a screenshot of it. If you didn't get that email, please sign up to receive hospital engagement meeting newsletters. When I'm done with my slides, I will put the link, because I know you can't get to it right now, but I will put the link to sign up for the hospital engagement meeting newsletter. It's just such a good way for you guys to know what's going on. We send out information that you need to know. So anyway, I'll put that in when I'm done with my slides. Next slide, please. The second thing we wanted to talk about is some housekeeping for rule. We have information out on our rule that talks about peer group and border hospital. The Colorado Rule sections 8.3005A and 5A5 are being updated to fix the alphabetical peer group references and add clarity that border state hospitals are assigned to an inpatient peer group based upon geography. Just let you know, both of these changes are just housekeeping in nature. So it doesn't change anything about what we're doing. We're just trying to make sure that when everybody reads rule, they know exactly what's going on. So the peer group for specialty hospitals was removed from 8.3005A in 2019 when those hospitals moved to a per diem payment methodology. And so the remaining peer groups are labeled A through C, and you can see on the slide the changes that we're making just to make sure that the narrative matches the alphabetical bullets that we have in terms of peer groups. Next slide, please. So the second part is border hospital. We're just adding clarifying language here that they get an in-state peer group average. After reviewing the language, we just realized that it really wasn't clear, at least and we just really want to be clear. Life is easier for all of us if we know exactly how things are working. So we're going to add in-state into that portion of border state hospital. And again, it's no change. They've been getting in-state peer group rates forever. We just want it to be clear in rule. So if anybody has any concerns or questions about these changes, please contact me. and my email is there and at the end of the slides. By end of day, Monday, December 8th, because we're going to be going to the Medical Services Board. That's where we have to go to get all of these changes made. Next slide, please. And here's the timeline for housekeeping rule changes with the Medical Services Board. We've got the public review meeting, then we've got the initial approval date, final adoption, and the earliest date that it will be effective in rules. So stakeholders are always encouraged to go to the Medical Services Board meetings. And I've also got a link in here for the web page if anybody wants to go to those meetings. And if nobody has any questions, and I'll obviously be around here for the end in case anybody does, I think I'll throw it back to Andrew. And I'm going to pop the newsletter link in the chat for everybody.
All right, thank you, Diana. So yeah, I'll take it over from here. I just want to go over some of the regulatory updates since the last few meetings. So regarding the 340B rate reduction, reducing that percent discount from 80% to 65%, as mentioned, we are still working through the state plan amendment for this. We had submitted it in August of 2025. We're still having conversations with CMS before that moves forward. So unfortunately, we don't have a whole ton of updates there. In terms of regulatory updates, I did also want to bring up the 1.6% rate increase that was effective July 1. We had previous communication around the rolling back of that 1.6% increase to be effective October 1. And the way in which that is being handled through the state plan amendment process is simply to allow the 1.6% increase to sunset effective 9/30. So that way the original rates would be effective 10/1. So that is currently the plan, and we are trying to engage with CMS to answer any questions they may have around that. Next slide, please. Okay. And then similarly, we had a state plan amendment that was submitted to CMS regarding the inpatient rebasing. As you're all aware, there's a big process around how we develop our inpatient base rates every other year. And that requires making some modifications to our state plan that aren't ordinarily accommodated through our general through the percent increases or decrease. In other words, there's a lot more changes that are introduced. So Diana worked with our compliance team, and we have the public notice that was previously issued, and that state plan amendment to accommodate those changes were submitted on September 30th. So we are, for the inpatient side of things, that includes both general and specialty. We already uploaded those rates into the MMIS system, so those should be paying correctly now. That was mostly to avoid having to do a lot of unnecessary reprocessing. So we're still awaiting CMS's word on that, but nonetheless, that is out with them. So also, this is a follow-up, this second bullet here on the regular rulemaking for modifying the hospital rate setting authority. This was introduced in September, and at that time we had to do an emergency rule per the regulations around how these rules are promulgated. Those emergency rules are temporary, so we have to bring this back as a regular rule this coming Friday at the Medical Services Board. So when we did present this originally, it was presented as an emergency rule, and that passed. Really what it was modifying our rate setting authority to allow modifications to be made via executive order. So this will allow that to continue past the emergency rule time period. So that will be presented on November 14th. And then the last of our upcoming rules are the regular housekeeping that Diana had just mentioned regarding the peer groups. So I would refer you back to slides 12 through 14 for more on those timeframes. Okay, and next slide, please. This is another ongoing commitment just based off of Senate Bill 25-121, which was to modify the Medicaid reimbursement for vagus nerve stimulation. So that was postponed indefinitely during this last legislative session. However, we do want to make sure that We are aware, this group directly, on any sort of access issues that are being created by the current reimbursements for vagus nerve stimulation devices. So if you are aware of any reimbursement concerns, please email us at this address. We just want to make sure that we are hearing from our hospital providers on these types of concerns, which will allow us to more effectively research this and see whether there needs to be any sort of modifications to the EAPG system or just really anything that can help accommodate any of those access issues. Okay, and next slide, please. I believe for this one, I am passing this to Diva.
Thanks, Andrew. Good morning, everyone. My name is Diva Wood, and I'm a hospital policy specialist here at the department. I wanted to take a moment during this meeting to go over a quick refresher for two billing policies. The first one we have listed here is for the birthing parent and newborn baby billing policy. Effective July 1 of 2020, services for the birthing parent and newborn baby must be billed under the ID number of each member, and those would be separate claims. Additional information for this policy is linked to the birthing parent and newborn section in the billing manual. The second policy we'd like to go over are covered/non-covered days. The days between admission and the date of and the to date of service, or TDOS, field are the total number of days billed on the claim. Value code 80 should be used to report the covered days of on the claim, and value code 81 should be used to report the non-covered days. The sum of these days should equal the total days on the claim less the day of discharge. Additionally, a current span code 74 should be used to report the from and through dates at a non-covered level of care or leave of absence during an otherwise covered stay. You'll see the link for this policy also attached to this slide. So I know I said a lot of words here. I'll pause for just a moment to let that sink in and give you a couple of seconds if you have any questions. Okay, not hearing any questions at this time, but if any do come up after this meeting, please reach out to Jessica and myself. Our contact information is on the last slide of this presentation. Thank you. I'll now pass it back over to Andrew.
Thank you, Diva. And if we could just stay on this slide for one moment, I wanted to go on discuss something else in that birthing parent and newborn billing. For those that were around then, this was in relation to a significant effort on our side regarding inpatient payment. We had, or I guess the department had originally been reimbursing mother and child on the same, or mother and baby on the same claims up until that change on July 1, 2020. So when we performed the separation of that, we were instead allowing providers to be able to bill the mother and baby claims separately. The reason why this was a significant issue for us is that this was a long-standing policy, and we wanted to make sure that in our APR DRG weights, we were reflecting this in a way that made sense. So there was a lot of payment modeling that went into it and development of billing guidance. So once we were able to do that, we were able to move forward with performing rebasing and using APR DRGs, the version updates, which following just industry standard on how we would like for providers to bill and how Medicaid would pay. So there was some history there, but again, now we reimburse the mother and baby separately. But I wanted to highlight this in particular because for any hospitals that may not have adapted their billing to this policy, there may be a potentially missing revenue stream in continuing to do it in the old way. So if anybody is still billing that old way, please be aware that you should be able to bill two claims for the mother and baby now, or multiple claims. Okay, next slide, please. All right, so we're actually flying through this meeting, so I just wanted to get to the last of our prepared content. Again, there's some facility rates website changes that we are currently going through, just trying to modify things to not only stay compliant with any accessibility standards that have been updated, but also just going through and making sure that our documents are up to date and have information that is pertinent to today's reimbursement methodologies. So These are the current web pages that are being impacted by this effort. If there are any changes that result in missing information that you're looking out for, please email the contacts that are listed for each respective website, and we should be able to get that information over to you. But otherwise, we should be complete with this pretty within the next before the next meeting. So this will be the last time that we have this reminder on here, but it's available in case, again, there's any resources that you thought that were on those sites that may be missing as we're going through those changes. Okay, and next slide, please. Okay, as mentioned, that brings us to the end of our prepared content. So if you do have any questions, comments, or solutions, please let us know either in the chat or feel free to speak up.
Uh, this Doug Muir with Common Spirit. I'm just curious. Obviously, it's challenging times all the way around with cuts. Uh, is there any thoughtful discussion as it relates to value-based payment opportunities, ways to be creative with the current and future budget cuts and constraints that are impacting behavioral health care provision, any Medicaid waivers that are being proposed, what's being discussed in order to not lose ground with regards to behavioral health outcomes and how we serve individuals and what we do with all the folks that are dropping off of Medicaid.
Hi, Doug, and thank you for your question. And I will say that unfortunately, we don't have a whole lot of people from the behavioral health side to really speak to any of that. So I certainly don't want to say anything that might conflict with any ongoing efforts that they have. I'm aware that there has been some Medicaid sustainability documents that were released within this year that may be addressing what you're asking about here. So I will try and see if I can get a link to that, and maybe that could help address. But otherwise, I think that these are important
I think
topics.
it applies to primary care too, just healthcare in general. Obviously, behavioral health impacts the healthcare spend. But just in general, it seems like community health worker and some of the solutions, the payments are going to be delayed. And so I'm just kind of curious if there's some like thoughtfulness as it relates to, folks that are most impactful as far as the healthcare spend and how we might partner to create creative ways to um, to partner between the Rays, Bossos, and providers to try to make sure those individuals get their needs met and supported so that we reduce the overall costs. Because right now it seems like some of those services that might make a difference are somewhat at risk. So I just don't know what's occurring as far as, you know, the immediate thing you need to do when you have cuts is, balance the budget. But after that, and it feels like that's being done, what are the partnership solutions in order to address the fundamental issue with regards to individuals that are Medicaid members that are that small number that makes up a very significant amount of cost and spend, what we can do, collaboratively, to move the needle to get at, what the state desperately needs, which is a reduction of expenditures.
Thank you, Doug. And I see Kevin Martin has his hand raised, so I'll go ahead and pass it to Kevin.
Yeah, those are all really good questions. I think it's maybe a little bit outside of the scope of the people that we have here right now. This is something that we can bring to future meetings, or if we get some advance notice, we can get, like, if we had these questions just a little bit earlier, we could have brought them to this meeting, but that's in the past at this point. If you wouldn't mind just like sort of sending those to us in an email, like the questions. I'm not sure if you have like really specific concrete questions that you want answered, or if it's more just like a very high level general thing. If you're just looking to collaborate with the department in general, I'd say maybe reach out to Kim, but we can definitely help direct to the right people. I just don't think we have the right ones here right now.
Okay, yeah, I mean, I'm happy to ask the question. I'm just curious as to whether there's a group, a team, a collaboration that's working on those issues and opportunities. It seems like we're at a critical point, this year and with next year's anticipated budget that it would be good to move in that direction. So I'm happy to outreach Kim about it, but I didn't know what I didn't know, so I didn't know if there was already some stakeholder engagement in that area that someone on this call knew about. So I'd be happy to frame up some emails on it. Thank you.
Yeah, and we definitely do have a lot of different areas working on a lot of different things. So that's where I'm just not sure where to point you at this point, because it sort of depends on exactly what you're looking for. Because behavioral health would be different from primary care, would be different from like if you're looking for specifically hospital related stuff, or just
Good.
depending on
Thanks.
what it is.
Yep. Appreciate it.
Mm-hmm.
Thank you, Doug, and thank you, Kevin. Are there any other questions, comments, solutions people would like to bring up? Okay, last chance before we wrap things up. Give it a few more seconds. All right, great. Well, I think we can go ahead and move forward towards wrapping up this meeting then. Next slide, please. So once again, thank you for your participation in today's meeting. If you do have any questions that come to mind outside of these meetings, feel free to send us an email. We should be able to get that directed to the right people if we can't answer them directly. But otherwise, we'll plan on chatting again in January, and please enjoy the holiday season. Thank you so much.